All right, good afternoon and welcome to this COMPAS webinar on federalism and public health. My name is Eric McGillivray. I'm a professor in the political science department here at Ohio State, and I'm the coordinator of this year's COMPAS series on COVID-19. As many of you know, COMPAS is a program of the Ohio State Center for Ethics and Human Values. COMPAS is an acronym that stands for Conversations on Morality, Politics, and Society, and the mission of the COMPAS program is to promote informed and civil discussion of important and controversial public issues. Obviously, the COVID-19 pandemic is one of the most important and controversial issues facing our nation and the world today. And today's panel is the last in our 2020-2021 series of COMPAS events that explore the ethical and political dimensions of the pandemic and the response to it. Next year's COMPAS theme will be Markets in the Open Society, and details about that program will be forthcoming in the coming months. More details about the COVID COMPAS series, including videos of previous events, are available at cehv.osu.edu/COMPAS. Today's panel, Where Should the Buck Stop? The Pros and Cons of Federalism and Public Health, will be moderated by my colleague, Vlad Kogan. I'll let Vlad introduce our distinguished panelists, but first let me briefly introduce him. Vlad is Associate Professor of Political Science here at Ohio State, where he's affiliated with the Institute for Democratic Engagement and Accountability, the Education, Governance, and Accountability Project, and the Translational Data Analytics Initiative. So I know he's going to hold us all accountable here. His research focuses on the study of state and local governments in the United States, with special emphasis on the intersection of politics and public policy and education and social policy. Vlad, take it away.
Thanks for that introduction, Eric. It's my pleasure to host this. And so I'm going to introduce our distinguished speakers. And so I will say at the outset that my introductions will not do justice to their very long and distinguished background. So our first presenter is going to be Donald Kettl, who is the Sid Richardson Professor at the Lyndon B. Johnson School of Public Affairs at the University of Texas at Austin. He specializes in public management and public policy and has served as a fellow at a variety of think tanks and institutions, including the Brookings Institution, the Volcker Alliance, and the Partnership for Public Service. He has way too many books for me to count and almost as many Lifetime Achievement Awards as well. So our second speaker is going to be Michelle Mello, who is a professor both of law and of medicine at Stanford University. And she's published hundreds of articles on health, including on topics of medical liability, public health, vaccination, and research ethics. And I know that last spring she had a piece in the New England Journal of Medicine talking specifically about COVID and implications for federalism and consequences of federalism. And I don't know too many law professors who publish so regularly in the New England Journal of Medicine. So with that, I will turn it over to Don, and we're going to try to keep comments about 15 minutes each, and then we'll do Q&A at the end. So thank you.
Thanks so much, Vlad. And thanks to everyone who has been involved in organizing the session for COMPAS. It's such a pleasure for me to be able to be here with you today, coming from scenic Austin, Texas here. And I want to have a chance to be able to explore some of these issues because of two things. One is that, as Michelle's pointed out in her work, it's unusual in so many ways for federalism itself to creep into this discussion about COVID, even though it's absolutely at the core. And so many of the ethical and moral issues that come along with it have to do with the way that the intergovernmental system has played out. And so that the real question here is, he says, trying to get a better slide here. Let me just stop. I clicked the wrong button, and I will get this for you here in a moment. This will work much better. And we want to look at the basic question of where should the buck stop, looking at the pros and cons of federalism and public health. And in many ways, the answer to this question is, I think, absolutely simple and clear, because the buck inevitably stops with communities. The basic issues about the way in which each of us as individuals confront the virus, and now increasingly confront the question of vaccination, has to do with the way in which we confront the puzzles and the challenges and the issues as they affect us where we live. The bigger problem is how we pass the buck. And especially over this last year, what we've seen is in many ways, disorganized collection of governmental responses, which has had in fundamental ways, strong, important, and in many ways, dangerous effects on the ways in which the virus has affected all of us. So the basic point that I want to make in this kind of summary of my presentation here today is that federalism has been often deceptively at the very core of the government's response to COVID. And at the same time, it not only has been at the core, but it's proven very costly. It's unquestionably the case that our reliance on state and local governments to respond has, I fear, cost lives in the process. We know that it's in some ways built political support, but sadly, it has also made the virus itself more dangerous and causing it to spread. The thing about COVID is that it is in some ways a very simple kind of process. It only cares about living and eating and making little baby viruses. It also cares about trying to find ways of keeping itself going and by producing variants, so that the virus itself operates through a series of vectors, which is up to itself to try to find ways of governing and spreading itself. When it comes to governing, the government's response to it, on the other hand, we have a series of governmental responses that have been working according to boundaries. What should the federal government do? What should state governments do? How about local governments? When we talk about local governments, what should be the respective roles of municipalities and counties? So that we have tended to think about our response in terms of a boundary-based, governmental-centered set of responses to deal with a problem that by its very nature and definition pays no attention whatsoever to these boundaries. And so our basic challenge in thinking about federalism is how we organize a governmental response to a problem we all share, to a problem that pays no attention to boundaries, but where our basic responses are organized and have to be focused on the way in which these boundaries operate. Let me point to some evidence about how costly I think this has been for the United States. Here are data from yesterday looking at the rate, and sadly the mortality rate per 100,000 people at a series of countries around the world, with Czechia and then UK being highest. But among federal systems, which I've circled here, the United States easily is #1 in terms of the death rate, followed by Mexico, Brazil, Germany, Russia, including the Russian Federation, and India. It is impossible to escape the conclusion now after a year that the United States among federal systems has the highest death rate. Other countries, and we'll be spending a long time trying to sort this out, have suffered worse. And we can look here especially at the UK and Italy, Italy in particular, which had a serious spread at the very beginning. But in the United States, among federal systems, with arguably the most advanced public health system in the world, we find ourselves, unfortunately, leading the world in terms of deaths. So, two conclusions. One is it's not clear that federalism itself is responsible for a high death rate, because there are other countries without federal systems with death rates that are higher. But on the other hand, it's also hard to argue that federalism in the United States has proven a more effective way of trying to deal with the virus, because other countries that also have federal systems have in many cases had substantially lower death rates. And the comparison here, especially with Germany, I think is instructive, where the death rate is far lower. In addition to that, if you look at the issues of deaths of different states according to a 7-day moving average, it's a little hard to read on this, but I just picked California, Florida, Texas, Washington, and New York here to be able to show the comparisons among different states. And you can see here early on a big spike in New York, but then we can see enormous variations along the way. And this is a count from the day at which the virus began to incur serious damage in different states. So it's not date specific, but dated from the time when the virus began to take off in each of these states. And the conclusion that I want to suggest here is that the virus itself is not just one phenomenon in the United States, but a very different phenomenon depending on where it is that you live. The nature of the virus and the nature of the response has in fact varied tremendously depending on where individuals live. Some of this is the product of the virus's own behavior, but unquestionably, it's the product of governmental public policy as well. Here's an example that I want to try to show about how this actually varies. Here I've compared South Dakota and Washington. South Dakota, which has taken largely a hands-off set of policies, and which as a result has tended to have one of the highest death rates in the country, and Washington, which was the ground zero for the early outbreak, but has taken a much more aggressive public policy. And these are complicated graphs, but in general, the colors that are in red mark dates where the state announced significant restrictions or closings. Green amounts to significant openings. And then blue amounts to deferring decisions to counties. And so these data are available on the Johns Hopkins University website, but I picked these two states to compare states that had relatively low and relatively high death rates. And you can see tremendous variation, not only in outcomes in terms of deaths, but also, and for our purposes here today, fascinating variance in terms of the ways in which the states have approached questions of public policy. In South Dakota, we saw a relatively late decision to close and a couple of decisions early on to try to shut the state down, and then a decision back in late summer to open it up, followed by not much of any governmental policy afterwards. On the other hand, you can see in Washington state a constant effort to try to both close and then close a little bit more and then change the closing, series of stages of reopening, then a bit to close back down again, close, open, and then a final decision to open more broadly more recently. So what we have here is evidence first that the virus itself has behaved very differently in different states. Secondly, we can see evidence that different states have approached the public policy decisions very differently. And one of the things that it's just slightly early at this point to be able to tie one to the other, but it's really impossible to escape the fact that the decisions of states to engage in more aggressive decisions have in turn made big differences in the way in which the virus has affected individuals. At the very least, what I want to try to suggest here is that state public policy decisions themselves, as well as the virus itself, have had wildly varying differences here in the United States. So the question is, what difference does it make? And in many ways in the United States, we've really had two different phases of America's response. In the first year, in the Trump administration, it was really largely a matter of making the effort to try to address the virus state-centric. The Trump administration strategy, for the most part, was not to acknowledge that the virus was real. When it became inescapable that it was real, the responsibility was left to the states, and each state was left to try to deal with things, for the most part, on its own, even to the part of competing with each other, and sometimes the federal government for the purchase of personal protective equipment. The second phase that we've seen just in the last couple of months in the Biden administration has been more federal-centric, with the federal government taking a much stronger role in both managing the production and the distribution, as well as the data and the messaging on the virus itself. What we see in the Trump response was that it not only downplayed the significance of COVID, but passed the buck to the states. And it seems to me, both in ethical and moral and in policy sense, asking the states to compete with each other to try to get the things that were clearly of national interest, including PPE, was simply remarkable, as well as the fact that, and I say, speaking here from Texas, where this issue has been one of the strongest in the country, a war between the state governments and the local governments in the effort to try to figure out how to respond, where local governments in many cases have wanted to be more aggressive in trying to create policies to battle the virus, and states have not only in some cases argued against it, but even attempted to shut that down. The result has been a wildly uneven response. And Columbia University suggests that even if all states have used tougher social distancing guidelines 1 week earlier, 1 week, it would have saved 36,000 lives. A more recent analysis says that if everyone had followed Seattle's plan of engaging in tougher masking and distancing requirements, that 300,000 lives, that's 300,000 lives across the country would have been saved. These numbers are just projections, and it's a little hard to be sure that in fact that would have been the result, but it is impossible to escape the fact that different strategies in different states have led to different outcomes that, because of the enormous variation among the states, have unquestionably cost Americans lives. And that's an unfortunate piece that is, I think, the cost, the very real cost of federalism as a result of what it is that we've done. The Biden administration, on the other hand, has essentially decided it's going to own the problem and to create clear messaging to try to address it, in part as a political calculation on the assumption that it was the failure of the Trump administration to address the problem more directly that may very well have cost Trump the election, but also a calculation that the best way to try to get the economy back on track was to create a more aggressive strategy to try to have the federal government own and direct the policy. They've done so through a massive logistics investment. Jeff Zients, the czar of the COVID response, was also the one responsible for trying to put Obamacare back on track after its rocky start. And they have been successful in being able to get more vaccines out and more vaccines in production, more of a stronger role in trying to steer where manufacturing of the vaccine is coming. To create as well a data picture about where things are going. But on the other hand, it's still impossible to escape the conclusion here that the data process is still muddled. We're still relying more on nonprofit organizations like Johns Hopkins that have created the basic metrics by which we're gauging the success. In many communities, the question of where to go for a vaccine, how to sign up, where you're going to be on the list, and how to get it is something that is extraordinarily difficult and has been especially and continues to be especially difficult for communities that are less served. And so for minority communities in particular, the risk, very real one, is that as the vaccine becomes more successful, that some parts of the country will be at least left behind, if not left out, in the process of vaccination. And that in many ways is the next major crisis that we're facing. So the challenges that lie ahead, we have to ask ourselves, what questions should be federal? That has to do perhaps with issues of logistics, including manufacturing and distribution of personal protective equipment in terms of creating vaccines and distributing it fairly, as well as creating information, not only in allowing people to sign up for vaccines, but knowing where we are so that we have a way to talk about a national problem that in fact is truly national, that requires a national language. What should be local? As I suggested at the beginning, the basic question of how should the buck be passed is clear, because ultimately communities are responsible for the way in which the process operates, because all response, and this, as with all other public health and emergency response issues, is that all issues are local. But we remain with big questions about how to navigate tensions, not only between the states, between Texas, which has sued other states for their role in trying to tamp some of this down, as well as the tensions between state and local governments, which has been a real epidemic in many places around the country, and which has shown one of the deeper and more fundamental problems of American federalism. The fundamental question, I fear, is inescapable, which is that America's reliance on federalism and passing the buck to state and local governments has in fact cost lives. And as we step back to assess this is a fundamental question that I think we're going to need to think about, to address, and to explore as we get into the lessons learned from this awful epidemic. So let me stop there. I'll be very curious for not only Michelle's reactions and her advanced discussion on this, but also a chance to be able to explore all these questions with all of you.
Great, thank you. And that reminds me, I should have mentioned this at the beginning, but we do have the chat disabled, but we do have the Q&A function working. So if you have questions that you'd like to see answered after our presentations, please go ahead and use that Q&A function. So Michelle, over to you.
Thanks so much. And thank you, Don, for that terrific overview. I think there are very few public health experts that would disagree with your thesis that the phenomenon of laggard or recalcitrant states when it comes to community mitigation measures like stay-at-home orders and school closures has cost thousands, if not hundreds of thousands of lives. I think what I might add to the conversation is some reflections from a legal perspective. You've talked about some of the disastrous decisions of the Trump administration. Some of the reasons why we didn't have more federal action, though, are structural. They're legal. It's not solely a matter of political judgment. So for the non-lawyers in the audience, I thought I might just visit that quickly. And then I want to add to some, to Don's thoughts about what well-functioning federalism might look like in this space of pandemic response. And then I'll close with a few reflections on the newest arena in which federalism is playing out, which is the vaccine distribution. So first, maybe just a quick overview of the legal framework for public health law. Our constitutional structure rests primary responsibility for public health with the states and by delegation to their localities. That's by dint of the 10th Amendment, which divides powers between the federal and state governments. and says critically that powers not expressly reserved to the national government are reserved to the states or to the people. In ordinary times, states exercise what we call the police power. It doesn't have anything to do with law enforcement. It has to do with laws of every description that serve to promote the public health, welfare, safety, and morals, exercising plenary power. They have very broad powers in this space, subject to some constitutionally protected individual rights and liberties like equal protection, anti-discrimination, or religious liberty. But if the federal government wants to do something in public health, it has to identify a specific constitutional hook that gives it jurisdiction to do so. The states don't. They can do pretty much whatever they like as long as they don't impinge too much on the activities and the sovereignty of other states. For the federal government, ordinarily, they invoke things like the interstate commerce power. That's the power that the Congress has to regulate business across state lines or within the United States and outside its borders. In recent years, that power has come under pressure from the Supreme Court that has issued a series of rulings that seem to suggest it's not as unbounded as we might think, that it prohibits the government, for example, from enacting such public health laws as a Gun-Free Schools Act to prevent firearm violence in schools, or a law to make it create a civil cause of action for domestic violence to protect women from intimate partner violence. And most recently, 2 federal district courts have suggested, in fact, held that the CDC's moratorium on evictions during COVID exceeds the scope of its power under the Interstate Commerce Clause. The other big power that tends to be available and used in public health space is the spending power. When Congress spends money and federal agencies distribute that money, they can put all kinds of conditions on how states can use it. And they can use that spending power to exert influence and induce states to do things they wouldn't ordinarily choose to do, up to a point. But here too, the Supreme Court has started to rein in that power in the 2010 challenge to the Affordable Care Act, the Burwell case. It famously held that the Medicaid expansion plan was too coercive on states because it was too much money involved, and this sort of crossed over into commandeering or coercions of states. So the federal government has to be a little bit careful there too, and they're getting sued again right now by the state of Ohio for putting onerous conditions on the COVID relief package. So my point is, the federal government does not have unlimited power to govern a pandemic. It has limited powers. Now, it can choose to exercise those wisely or unwisely, and I would agree it's been unwise, but there is this legal framework that it has to stay within. And so during disease outbreaks, typically what the federal government does when it works well is it deals with borders, people coming into and out of the US or traveling across state lines. It deals with the instrumentalities of travel, like airlines, and it provides lots of technical support and assistance to states and localities as they discharge their duties. Now, in extraordinary times, in times of emergencies, all this shifts a little bit. Both the federal government and the states get more power through special statutes that are time limited and have some checks and balances, but greatly expand what these levels of government can do without involving legislatures. And most of what's been done under COVID has been as part of those emergency powers. But even there, the emergency powers given to the federal government have to be cabined into its domain of the interstate or inter-border issues. So the primary concern about this emergency legal framework that gives these extra powers to the federal government has long been that officials will abuse these powers, that they'll overreach. And what's ironic about COVID is that they did the opposite. They underreached by a huge margin, but that's pretty historically distinctive. Even under really limited outbreaks like the Ebola virus disease outbreak of 2014-15, states and federal officials really kind of overreacted. So we have to be conscious that we're living in a particular historical moment, and any conversation we have about balances of power has to be cognizant that those powers can be used in a variety of ways, including abuse of power. So let's revisit this key issue of how much federalism is to blame, having reviewed this legal framework. Maybe it's helpful to do a thought experiment. What if there were no federalism in the realm of public health law? What if the states didn't have plenary power? What if the federal government had plenary power and the states were there to kind of carry out its orders? Would that be better or worse? Well, consider 2 alternate realities. First, let's think about reality A. Reality A is we have this structure And we have a really insightful, wise, savvy, well-performing federal executive and a Congress that gets things done. So in this reality, the federal government performs beautifully. It leverages a strong national health system that it has built and resourced over many years, including a state-of-the-art data collection system that's nationwide. It consults the best available evidence. It works closely with experts, and it imposes community measures nationally to prevent the spread of the disease, and it changes them as evidence evolves. It immediately makes resources available for development of countermeasures like vaccines and procurement of necessary supplies. It works with a high degree of transparency. It leverages the most trusted figures in government and non-governmental sectors to deliver public health messages. And it's in constant contact with governors, to assess their needs and help them execute their responsibilities. Now consider reality B. In this reality, the federal government has plenary power over public health, and it blows it completely. So it under-resources the CDC and other agencies for years. It is indifferent to data collection and IT infrastructure. It's low on subject matter expertise, and it ignores the experts that it does have. It's indifferent to evidence and evidence collection. It opts not to impose or spearhead any community mitigation measures. It publicly downplays and obfuscates regarding the significance of the public health problem. And it chooses to put all its eggs in just two baskets, that will get to herd immunity through a vaccine, or will get to herd immunity naturally by people getting sick. We just lived through reality B. And what I want to propose is that federalism is a hedge against reality B. States' responses a lot during COVID, but what if states had not been empowered to act? Being covered by a patchwork quilt of state responses is a lot better than having no covers at all. So just imagine the outcomes if states had not stepped forward to fill the gaps left by the national government during COVID. We would have had a much worse catastrophe on our hands. So to me, federalism is not the problem. In this case, federalism was a backstop that gave us a next best solution that we otherwise wouldn't have had. The particular way in which federalism played out here was, of course, the problem. Now, state-led responses are not a natural fit for pandemics. Pandemics now are global. Our public health legal framework evolved from a time where outbreaks were local because people didn't travel very far, very fast, and that worked well. It doesn't work well anymore. But there are ways of expressing this federalist structure that are functional, even in an age of global pandemics. The way federalism should work is not that for federal errors and omissions, but rather that both levels of government work together. They operate within their respective domains of authority, and they support one another's efforts. So what would this kind of well-functioning federalism look like in the next pandemic? Because there will be one in not too distant future. Let me just make 5 points about what I think that would look like, aside from the obvious point that all the leaders need to be guided by scientific evidence. The first is that the federal government can and should play a much more active role in coordinating states and exerting pressure on governors to do the right thing for public health response. They have got carrots and sticks at their disposal that were not used during COVID and can be used. They can convene summit meetings, as the Biden administration has begun to do, conduct regular briefings with governors to exhort them to reach a consensus on a coordinated national framework for the orders that states have the authority to put in place. The federal government can use funding conditions, as it has begun to now, to exert this kind of influence over states. They can make all kinds of conditions on the receipt of COVID relief packages. And not only does that exert influence, it also gives political cover to governors who maybe would like to implement community mitigation measures, but know that they have enormous popular resistance to doing so. People want the money, they're going to have to accept that trade-off. The federal government can allocate scarce resources like drugs and ventilators differentially to states that play ball on prevention, instead of allowing them to sop up resources, having taken no steps to prevent disease spread. They can provide economic assistance to head off arguments in states that there's a trade-off between community mitigation and the economy. We only had that trade-off because we didn't intervene with the community mitigation measures early enough that they could be temporary. And the government can make sure that any CDC guidance, like on school reopening, for example, is supported with the funds for governors to actually execute it. And finally, the federal government can lead by example by implementing preventive measures in areas where it does have jurisdiction, like federal prisons, military bases, detention centers. All of these are places where the government is free to do whatever it likes on the federal level. So coordinating and exerting pressure on states is point one. The second point of this perfected federalism, I would say, for response is to make better use of regional alliances among states, to pool resources, and to distribute scarce resources, and to develop a coordinating messaging strategy. One of the saddest aspects of this pandemic response to me was to see states fighting among themselves over what to do, blaming each other for, exporting vacationers who were infected with COVID, putting up walls to prevent interstate travel, and fighting over PPE. Instead, we saw later in the pandemic, a few blocks of governors coming together in the West Coast and the Northeast to try to create these regional alliances and work cooperatively. That should have been done from the get-go. The third point is that the federal government can make much more use of its procurement powers, including the Defense Production Act, which it is now using to compel production of critical supplies, and continue, I think, the great success story of the Trump administration response, which was its support for research and development into vaccines and the pre-purchasing of those vaccines to create a solid market. That kind of provisioning should be done in every pandemic, and it's just ridiculous to expect states and localities to suddenly get good at and scale up programs that they have no experience in running and no money to do so. The fourth point I make is that the government can use its interstate commerce powers to regulate economic activities that affect interstate spread. So the cases where they've got in trouble with the court have been cases where the federal government is trying to regulate non-economic activities like intimate partner violence. But there are all kinds of economic activities during a pandemic that spread disease across states. When Amazon drivers, for example, cross state lines, or when airlines operate without masks, the federal government should be out front with those activities to try to keep outbreaks more local as they used to be. And then finally, the federal government can be much better about attending to its global responsibilities. That was another great failure of the federal response during COVID, was this extreme pulling in of putting up walls around the US fruitlessly because microbes don't obey boundaries. They don't even obey travel bans. And by failing to address the epidemic where it begins and in the places where it spreads, even after we have vaccines here in the US, we risk recurrences of this and other outbreaks. So attending to the needs of the global community by participating in international organizations is really critical. It's something that states can never do. So that's my vision for what federalism can be and should be for pandemics. Let me close with just a minute or two reflections about vaccine rollout, which is where a lot of our attention is now. And it's another example of where federalism is playing out. In this case, we had two excellent national committees make evidence-based recommendations about how to allocate vaccines. Not surprisingly, those two groups came to almost exactly the same set of conclusions, working independently about which allocation schemes would save the most lives and prevent the greatest burden of disease. And states then did their own things. Some followed those plans, some modified them a little, some modified them a lot. So there are some things that this issue has in common with other aspects of the pandemic response. There are procurement challenges with the vaccine rollout, obviously, and there are big questions about the role of government coercion versus individual liberty. All these things have commonalities with other community mitigation measures during COVID, but there are some distinctive issues too. And probably the biggest one is that vaccine prioritization is inherently value laden. We talk a lot about how the pandemic response needs to be science-driven, but issues about resource allocation can't be only science-driven. They inherently reflect value judgments. Do we want to save the most lives or the most life years, which is a different group of people, a younger group of people? Do we care about reducing morbidity or only mortality? Do we care about directing resources to the least well-off? States have very different reactions to those kinds of questions. And so a question I'd raise perhaps for discussion is, do we want to allow federalism to flourish in this instance so that states can play out those values? in vaccination distribution, because that's one of the original purposes for our federal structure, is to allow states to express the values of their citizenry in public policy. On the other hand, as with all other aspects of the pandemic response, allowing them to do that has cost lives, because they have resulted in allocation schemes that will not save as many lives or life years as the federal recommendations. So it's an interesting example of some of the ongoing federalism concerns during the pandemic. Thanks very much for your attendance and engagement. I'll pause there and take any questions.
Great. Well, thank you both so much. A lot of really important, interesting food for thought. So I wanted to ask you both, kind of along the lines, Michelle, of your thought experiment about the counterfactual. And I think all of us often have a tendency to fall into what some people call the nirvana fallacy, where we see everything that's wrong with the world today and compare it to some counterfactual that's 100% perfect, when in fact that's probably not the counterfactual. And I wanted to, I guess, ask and compare and contrast, I think, the PPE situation and the vaccine situation. So as both of you mentioned, in the spring, there were states fighting against each other to get PPE. We had that quote from Governor Cuomo, who compared it to eBay, where states were basically bidding on ventilators. And I think what's interesting is, I think Europe saw something similar, and they decided, for vaccines, we're going to do it differently. We're going to centralize, and we're going to have this coordinated effort. And now that we're looking back, many people complain now that the EU system is too centralized, that they're doing a far worse job getting vaccines into arms. And part of it is the procurement issues that Michelle mentioned, but part of it is also just the delivery part of the vaccines you got, how many are getting into arms. And in many ways, the US is a leader in the world. And so what do these two experiences tell us about both the benefits and the costs of federalism, right? Because it seems like both we saw problems on both sides with PPE and vaccines, but in one case, there was too much chaos. In the other case, in Europe, it seems like it's too much centralization and not enough of the decentralization.
Yeah, that's a great setup. And in many ways, it is a microcosm of the broader problem, right? Which is that, in theory, centralization should be more efficient, should result in cost savings and distributional efficiencies. But we're talking about massive scale. And so for both PPE and vaccination, if you're going to do that, you better be really confident in your central procurement and distribution structure. And I don't think we had anything approaching the kind of system in place to do that would have been needed to manage that all on an exclusively federal level. Why have other countries succeeded where we haven't? Well, for one thing, they have national health systems, and everybody in those national health systems is on the same information platform. Israel, granted, its population is the size of San Francisco, but they're all members of just 4 different health maintenance organizations. They're all messageable through IT platforms that are functional and widely used. It's a small country. They can get that vaccine around quickly. So of course, in a system like that, centralization makes perfect sense, but our system of healthcare is completely decentralized. Of course, about 35 million Americans don't have a health insurer at all. So any plan that was going to rely on that with counties as a backstop was destined to have inefficiencies. But I'm not sure there was an alternative in place at the federal level that would have been more functional.
And let me not only agree with that, and play with a thought experiment in just one respect. Look at New Zealand, which highly centralized response, highly effective response. They're back watching football and people going to the beach and going to concerts again. And so their centralized response worked terrifically well. However, it's an island nation. It's a lot easier just to shut things off, which they did. It's a relatively small population that's very homogeneous with a national health insurance system. So if you grant all those conditions along with strong leadership, then there's a strong argument that centralization can work. In a large country that you can't wall off, where you have enormous variations and enormous differences in political culture without a national health system or without much national stuff at all to begin with, that makes it be much harder. So the case for federalism here is inescapable, I think. The real and underlying question, as Michelle's pointed out, is first, what could the federal government itself have done better to encourage stronger coordination among the states? And in that respect, I think it's worth going back and looking at the Johns Hopkins website, which is a fascinating piece and which exists purely because the federal government did not do it. And so Hopkins decided to do it itself. What Hopkins has done has been terrific, but should we have to rely on the good graces of a nonprofit that decides to take up leadership? If it had not, we would be in a very different place today having that conversation. That's an example of the kind of thing that the federal government could have, should have done. On the other hand, the question about federalism also gets down to not just the question between the federal government and the states, but especially between the states and the local governments. And it's arguable that one of the biggest tensions that we've seen has been this hidden one about the lack of coordination and leadership between the state governments and their localities. And many of the biggest frictions and many of the biggest problems have in fact emerged that way, given the fact that the virus itself can only be attacked at the local level and that communities are the front lines of public health. In many ways, the unsung piece of America's public health system are counties, which have in most cases the primary responsibility administratively for doing this, where we've tended to push counties to the side of this national discussion, and where there's been tremendous friction between the states and the counties and the local governments that reside within them. We've seen huge problems that we need to try to deal with, so that the basic questions of the 10th Amendment, which are an important break on the role of the federal government, really doesn't get to the underlying questions about the tensions between the state governments and their counties and the local governments. And in many cases, those have been the single toughest collections of things. More different rhetoric from the federal government, and especially from the president, about whether or not this was a real thing that required a national response would have certainly been helpful. But even with that, if state governments have continued to fight with their localities and continue to fuel that kind of friction, we would still, in all likelihood, have ended up in the same spot.
Great. If I could ask you both, I think what is now becoming the hot button issue of the pandemic, which is schools, and what can we learn from the schools' experience that speaks to this question of federalism? I mean, in some ways, the U.S. has been an outlier, both in terms of closing the schools and how long we've kept them closed. But I think in other ways, it illustrates some issues that we haven't talked about yet, which is partisanship and interest groups. And I think it's interesting, Michelle, you mentioned, in an ideal world, what the federal government do? Well, the federal government would, pressure states, it would attach conditions. And, what we saw in the summer when President Trump and Betsy DeVos said schools should be open, we saw huge pushback. We saw polarization amongst partisan lines, to the point that in the fall, the best predictor of whether schools opened was the partisanship in those areas, not the public health status. And if we were, to go back in a time machine and rerun that experience and then say, if you want federal CARES Act dollars, you have to reopen your schools 5 days a week. It seems to me like that would have been an even bigger partisan line and explosion. And so I wonder what can we learn from what happened with schools, and what does it imply about, again, this broader system of federalism that we have?
The basic question of polarization is so important, I think, because it's not only the matter of what it is that science says, and science has had a hard time trying to wrestle with this question. To what degree are kids themselves vectors? To what degree are teachers at greater risk being around the kids? To what degree are schools important as a way of providing full-time daycare to allow parents to get back to their jobs? And to what degree are all these questions nestled into the basic situation of where in some school districts, the teachers' unions have extraordinary power, and where teachers have felt uneven, they push back politically. In other cases, that has not been the case. And so we see ourselves nestled within this really tough battle back and forth. I think it underlines this point that I was making previously about the important role of local governments and the tensions between what local communities think and what state and federal governments want to do. But the idea of trying to force the schools open one way or another, given the fact that the science has been unclear, that the relationships between local governments have been difficult, between the state and local governments and local school districts have been so problematic, and in particular where the role of the teachers' unions has varied so incredibly, I think paints a very interesting picture of where we are. Now we're beginning to get back to schools. Schools are beginning to open in person again. We're beginning to see some of that. We'll see just how well that plays itself out. But there's no mistaking the fact that teachers have said that they don't want to be essentially the daycare workers that nobody else can afford, putting their own lives at risk in what they view as a risky situation, given the fact that the science itself has been so unclear.
Let me just Let me just push back a little bit on your hypo, Vlad, because I don't think in any world anyone would have wanted the CARES Act, which remember was passed in March of 2020, to have provisions requiring schools to reopen. We did not know very much about that virus at all, and we definitely didn't know anything about kids. I think the more salient hypo is, what if the Biden relief package had that provision? Okay. I think that'd be a good idea, because what we have managed to do over the last 6 months is clear up a lot of the factors that have kept schools from reopening. And the leading factor that has really created this schism, as we've already talked about, Don, is the polluted information environment, which was a direct result of Washington influencing CDC guidance. That CDC guidance, things would come down and the public health community would just go bananas on Twitter saying, can anyone explain this? It was baffling. And then to the extent that there were useful bits of information, there were no resources to match it. So again, it comes down to a carrot and stick. You've got to provide levers to induce states to do things that are supported by the evidence. You also have to resource them to do it. And that's the final comment I just have about schools, which is, it has astounded me the extent to which school reopening decisions have been led by educators who have no expertise in public health, no ability to increase their budgets, have to grapple with multiple constituencies, including the teachers unions and parents. And I can tell you here in Silicon Valley, that has been an enormous brouhaha, pushy parents. In what world should this be a principal or superintendent's decision? This is a decision that has to be based on two questions. What is the healthiest thing to do? And do we have the money to do it?
And if I could just, I know we want to turn to some questions too on top of that, but I can't resist underlining one important point, which is how much the evidence itself has been politicized. That we've been dealing with a question of so often people saying what we need to do is to rely on the sciences and what the experts say. But the level of expert advice and the way in which it's both interpreted and distributed through communities has been hyper politicized from the very beginning on this, which itself has then shaped policy decisions. One of the things that I'm concerned about is that sometimes there, in the broader national debate, is we ought to focus on and do what it is that the scientists say. And it turns out that there's enormous uncertainty, especially in the early stages, about what the scientists know, about what it is that the best guidance will do, about whether or not we're really sure about the way in which that works, and then ultimately about the political judgments that have to be made on the basis of that uncertainty. And so that the fact that the facts have been so politicized itself, I think, is an important piece that we're going to need to spend a whole lot more time when this is over paying attention to, I think.
Great. I'm going to combine just a couple of, I think, related questions, which is again, trying to bring the politics into the issue of the federal role and in the distribution of scarce resources in the pandemic, whether it's vaccines, whether it's PPE. I think we've talked about it in terms of, again, having some coordination. Michelle, you talked about it in terms of as an incentive, right, as a way to encourage states to do the right thing. And I think so the two questions are, should we worry about politicization, right? So early in the pandemic, there was claims, at least, that Florida was getting an undue share of ventilators because it was a swing state with a supportive governor. And relatedly, what are some unintended consequences? So one of the questions asks, we know that state legislators are not very good at being responsive to the preferences of their constituents. So now if they are being pressured to meet some federal distribution guidelines, is there a concern that really the most vulnerable people in those states are going to get the short stick because of bad or illegitimate decisions that state officials are making in order to comply with these federal directives and pressures? So I'll open it up to both of you.
Well, I'll just take that briefly, but I'm interested in Don's thoughts on the sort of political economy of the issue. I mean, yes, anytime you condition federal funds for social programs on states doing something, and those social programs primarily benefit the least well off, you have the concern that the most disadvantaged are going to be hurt when the state legislators who are beholden to more money to interests simply tell the federal government to kiss off with it and, thanks, but no thanks. So I think that's why I say, something like the Biden relief package is a better vehicle for conditions than the CARES Act. So that's a relief package that's going to reach and give money to a very broad swath of Americans. Contrast that to something like Medicaid expansion, which lots of states decided to reject There wasn't much of a public outcry because it doesn't affect most of the public. You have to be insanely poor to qualify for Medicaid. So that's sort of an out group. I think this time around with severance, we're kind of all in the in group. So although it's a risk, I think it's a risk worth taking.
And two thoughts on that. One is to pick up on Michelle's point about the underlying politics here. And what's happened is that the differences between the states and the politicization of some of these issues is increasing. And so the propensity of states to go in different directions is not only growing, but to have the gaps between the states increasing at the same time. So one of the things we have to be concerned about is, especially when it comes to issues of inequality, that the more we rely on the states, the more we're pushing the states in different directions in all likelihood, because they're more likely to push decisions in ways that increase inequality among them. But when it comes especially to this, I think, looming crisis about the difficulty of trying to reach different populations, especially chronically underserved populations, I think in many cases, it's not so much a matter of policy as much as it is a matter of the implementation of this. It's a matter, for example, of having massive evacuation centers, drive-through centers, as they have in many parts of the country, which works great as long as you have a car. That if you have vaccine distribution hubs that require people to travel to get there, which works great as long as you can actually arrive, where the different patterns of communication and different systems of sign up. Turns out that there's some places where it's just trying to just navigate the process for signing up for a vaccine requires a fair level of computer sophistication and internet access, which many people don't have. So that the underlying pieces of this that are likely to produce deep patterns of inequality in terms of the distribution of the vaccine are not so much the matter of explicit policy decisions as much as the implicit kinds of problems that are reinforced by other patterns of inequality that already exist in society. So if we're interested in trying to make sure that we don't come out of this in a way that creates a new pattern of inequality of vaccine access layered on top of the inequalities that have already occurred in terms of who it is has been most effective, we're going to need to try to focus very carefully on first identifying that as an issue, second, shining a bright light, even through some naming and shaming, through data systems, through ways of ensuring that there are not our incentives and capacities, but that we pay a lot of attention to these questions from the very beginning so we don't end up producing the distinctive results that I fear may happen. So it's not so much a matter of state legislatures characteristically deciding not to try to immunize the poor. It's that we have systems that where the structures are so complicated to try to navigate that we may end up with that despite our best efforts unless we engage in better efforts.
So in the last 5 minutes, I think we have time for one more question. This is, I think, a really great question because we have spent a lot of time talking about federalism and states versus the federal government. But as both of you mentioned, the virus knows no boundaries. So in some ways, it's a global problem. So I guess, how do we think about the global context and the role for global governance in the distribution of vaccines and the distribution of PPE, and I think the issues that this pandemic has revealed?
Yeah, so the public health community has some general answers to those questions. Every time we have one of these epidemics, all kinds of blue ribbon committees get convened to do a postmortem and figure out what we need to do differently next time on a global scale, and then nothing happens. So then we write the same report a few years later. There are some distinctive things about this one, though, that has made it especially a hard problem. And one is with respect to the vaccine development. The fact that the US underwrote such a massive investment in that relative to everybody else in the world, which has, I think created a not totally illegitimate sense that we're entitled to a certain share of the first rounds of doses. Ordinarily that wouldn't be such an issue. And so international institutions that are set up to distribute vaccines globally can and should be used, and the US should receive its fair share along with others. The other thing that's distinctive about this pandemic, really distinctive, is that the higher income countries got hit the worst. That is just very, very unusual. And so again, it kind of flips our normal presumptions in the public health community about how higher income countries should behave with respect to lower income countries on their head, because usually we'd be talking about, we should, build health system capacity in the outbreak zone so we can detect early and stop it at the source. Well, we're the source this time around. The United States is the source. So, I think this time we've shown greater selfishness, and it's not all warranted, but there are aspects of it that are warranted because we've been a huge part of the problem.
And it is an important lesson about the need for us to clean up our own act before trying to dictate to the rest of the world about what's going to be happening, and to think carefully about our public health capacity and our public health systems. But I've been, as you can tell, thinking more about the problem over the next hill sorts of issues. And the big challenges, if you look at the projections about how long it may very well take to get the vaccine to developing countries and to less served communities. There are two issues here. One is a matter of basic equity. It's a matter of trying to ask ourselves and ask the global community, as a community, what our responsibility is to those who don't have vaccine manufacturing facilities within their borders, with the effort to try to find a way to be able to spread it and how to make sure that we can immunize people. And the second issue is that the longer that the virus is out there percolating and spreading from person to person, the greater the chance that more variants will develop that could be resistant to the vaccines that we already have. And so it is in our collective global interest as a community to find ways of trying to address those issues. And it's in our individual self-interest to make sure that we do so as well, to make sure that we don't end up inadvertently creating the breeding ground and the petri dish for a new round of the virus that may be resistant to the vaccines that we've got. But it really raises important questions that says, on the one hand, that yes, we have a right to be selfish because we invented a lot of the vaccines and spent a lot of the money, that we really need to be alert to the fact that we caused a lot of this problem and therefore have a responsibility to try to stop it ourselves. But it really calls for a much broader global conversation about responsibilities as well as the science on this, that for the most part we haven't really been talking much about yet because we're all concerned about getting in line to get our own. But I really see that as the next issue hiding around the corner that we're going to need to pay careful attention to, because otherwise it could have lots of very dangerous effects as we go down the line, and ultimately get to the answer to the question about how much longer are we going to have to wear masks. And the answer is maybe a very long time unless we pay attention to this.
Right on time. So that's perfect. Thank you both so much. This is, I think, an outstanding panel. And thank you to all of our attendees as well. Eric, should I turn over to you? Do you have any closing remarks? Or
I'll chime in as a ghostly voice. No, it'll just end on its own. But thank you all for a really great conversation. Really exactly what we were hoping for. And thanks to our audience for attending, and we'll see you next year for the COMPAS on Markets in the Open Society.
Thanks for having us.
Thank you, everybody.